the amount of patients that I saw that were morbidly obese, who needed a hip replacement or a knee replacement or a back surgery or something, but couldn't have it because of their weight, or maybe their diabetes was too out of control, was alarming. These people had been told, hey, you need to lose some weight and we can do this surgery for you. And it started for me as I felt compelled to give them a better answer than good luck losing the weight. So I started pointing them in the direction of, ketogenic style nutrition. Lo and behold, people came back to me saying that they were down 20, 30, 50, 100 pounds without having to exercise much. Because the thing about my chronic pain population, exercise is really hard. To come in and try to ask my patient who's 380 pounds with terrible knee arthritis, maybe a back surgery before they're 65 years old, asking them to get out and do a lot of walking, any kind of strenuous physical activity is not feasible, really. Not enough to move the needle on weight loss.
Morning, everybody. How are you guys today? We've got Dr. Chris Netzel on today. I assume that it's listed as Archer. Is that correct?
So yeah, that's kind of funny. My son, who's 6, managed to change that, and I don't know how to change it back.
Okay. I was wondering where that came from. So anyway, Chris, well, thank you very much for taking the time out of your, I'm sure, your busy day to do this. I think you go by the handle of Keto Pain Doc, if I'm not mistaken, on I believe Instagram, and you are a anesthesiologist, pain specialist. I used to be married to one, so I'm very familiar with what you did. And obviously had some patients in common with that. It's an interesting and challenging field. Just tell us your background. I know I kind of gave a little bit of away, but go ahead and give us your background if you don't mind.
Yeah, sure. So I'm an interventional pain medicine physician currently working in Jacksonville, Florida. I am trained as an anesthesiologist first. I did most of my training at the University of Wisconsin-Madison, college, medical school, and then residency there. I did my fellowship at Rush University in Chicago, Illinois, before practicing for a couple of years in Madison, Wisconsin, and then eventually moving down to Florida. And I, as part of sort of a multimodal approach to chronic pain management, I utilize ketogenic and or carnivore style nutrition to sort of help my patients, not only with their overall wellness, but specifically for their pain.
Yeah, they're just for the people who don't understand what you do. I mean, we'll get into the nutritional standpoint. What does a pain doctor do, an interventional pain doctor? Can you give us an example of some of the procedures that you might perform or some of the day-to-day routine things you would do in the conventional medicine sense?
Yeah, absolutely. So we do everything from sort of less invasive methodology, and most people are familiar with medications, right? Whether it's nerve pain medicines or muscle relaxants or even the opiates, but we also are trained in interventional techniques. So, injection therapies, whether it's epidural steroid injections for pinched nerve pain, injections meant to treat arthritis in the back or in the joints, for example, all the way up to more interventional and invasive techniques like spinal cord stimulation, intrathecal targeted drug delivery pumps, dorsal root ganglion stimulators. I actually do a little bit of minimally invasive lumbar decompression for pinched nerves in the spine too. And so very, very broad spectrum of what we do. It's not just medication management.
Yeah, and it's a challenging patient population that you work with. Folks with chronic pain definitely often have, understandably, a lot of psychological things going on. It's because, if you're in pain pretty much your entire existence, it wears on you, believe it or not, as I'm sure you're well aware. How did you get into, because you've got all these tools at your disposal, and obviously some of them have greater efficacy than others, and a lot of it is, like I've taken care of people with spinal cord stimulators and all this stuff. And by the time they're at that stage, things are pretty far gone in a lot of cases. But how did you start to look into nutrition? This seems like an odd, I know why it works, but how did you get there?
So I think just like a lot of us in this space, it started with my own personal journey. I came out of my fellowship in pain management not in a good place. I was 45 pounds overweight. I had joint aches and pains when I shouldn't have. I was, 31 years old, and I was depressed. I had no energy. I didn't, things weren't going very well for me. And I had tried the usual things everybody talks about, right? Low fat and sort of calorie restriction, working out, exercising a lot. And, in my 20s, that worked. I could do that, and temporarily I could get the results I was looking for, but it always came back. And, here I was in my early 30s. I had a family. I didn't have as much time. And, I started looking around for other options, other ideas. And I stumbled across some of Gary Taubes's books. And honestly, it just went down the rabbit hole from there. I, started reading doctors, Finney and Volek, Dr. Westman. I stumbled across your books, Paul Saladino's works. And, the more I read, the more I became interested. And I, started just implementing it in my own life. And, in the first sort of 2 to 3 months, 25 pounds melted right off of me without me stepping foot in the gym once. And it was just about what I ate and when. And I said, well, there's something to this, and at that point I started to feel better enough to go, start working out in the gym a little bit, and another 20 pounds just immediately came off of me. And I started to put on muscle again. And my sleep was better. My energy was better. I no longer had those joint aches and pains that I was having. I have had both of my ACLs replaced. And so my knees were starting to bother me, way too early in life. And so, I was noticing that in my own personal journey, but at the same time, I was starting my practice as a pain management physician, and 80% of the patients that walked into my clinic had one or most of the components of metabolic syndrome, most of the time weight. And I mean, the amount of patients that I saw that were morbidly obese, who needed a hip replacement or a knee replacement or a back surgery or something, but couldn't have it because of their weight, or maybe their diabetes was too out of control, was alarming. And up until this point, these people had been told, hey, you need to lose some weight. Good luck. Let me know when you do, and we can do this surgery for you. And it started for me as I felt compelled to give them a better answer than, good luck losing the weight. And so I started pointing them in the direction of, ketogenic style nutrition. And, lo and behold, people came back to me saying that they were down 20, 30, 50, 100 pounds, without having to exercise much. Because the thing about my chronic pain population, exercise is really hard. To come in and try to ask my patient who's 380 pounds with terrible knee arthritis, maybe a back surgery before they're 65 years old, asking them to get out and do a lot of walking or any kind of strenuous physical activity is not feasible, really, at least not enough to move the needle on weight loss. And so that's kind of where things started for me. And I started to have success. And as I kind of continued my own education and my own, down the path that I started to get more certification. I got trained by the Nutrition Network in low carb, healthy fat lifestyle. I've actually taken all of the CME to be obesity medicine certified. I just have to sit for the exam. But I started to sort of more formalize my recommendations a little bit. And, I'm just a pain guy, but I've been able to sort of help people with their weight, taking people off their diabetes medications, just like, your community and what you guys are doing are seeing. And along the same, timeline, these patients are noticing that their pain sometimes gets better without me having to stick them with a needle or give them a pill that has side effects with it. And so that's been kind of my journey up until now, using this in my practice.
How frequently are you successfully able to convince people and actually have them go through actually doing the dietary change? A lot of these people are just, you get to see them at a very vulnerable point where this is like bad stuff. If I'm going to a pain doctor, things are really, really, really bad. And so sometimes that's a big enough wake up call, but not always. And so what would you say, and how often do you get an opportunity to actually talk to the folks about it?
It's a tricky thing. There's no question. I'm still operating under the sort of the conventional model where I see patients every 15 or 30 minutes, just depending on the visit. I take every opportunity I can. And I think that a lot of patients come to me really scared that I'm going to give them pills, or they're really scared of the procedures that I can offer. Whether or not they really kind of understand what that involves is a different question. But a lot of them are really looking for any alternative that doesn't involve pills and procedures or surgeries. And so those people are, it's really well geared for those people. On the other end of the spectrum, there's people that have tried a whole host of things, medications, surgeries, injections, and there's not that much else that they can do. And so for those people, they're, willing to try anything at that point. And I, pitch it to them in that way. But even people that are in the middle, people with metabolic syndrome or, diabetes, I saw a gentleman today who, he has metabolic syndrome. He's diabetic. He's on about 100 units of insulin, and his A1C is like 5.9 or 6. And so he thinks he's really well controlled. And I said, well, to me, that's not well controlled. That's just covering up the problem. If we get you to a point where you don't need that medication, you might feel better regardless of what else we do. And not everybody's ready to hear that. Not everybody's ready to consider nutrition as an option from a pain standpoint. But I certainly try to make it a point to talk about it as much as I can.
Can you think of physiological reasons may have an impact on pain? Have you looked into the physiology a little bit on this?
Yeah, I think there's at least 4 reasonably solid reasons that explain why pain gets better when we improve our nutrition, specifically with ketogenic diets. And, the most obvious one is weight. And you probably know this better than I do, some of the orthopedic literature about, if you drop a pound of weight overall, your knees or hips experience, 4 to 5 pounds less of stress or strain on those joints. How that exactly translates to the back or the spine is not as well understood, I don't think, at least not to my knowledge. But, it certainly is going to improve situations from a mechanical standpoint on the joints. Inflammation is a big deal. We know metabolic syndrome is very inflammatory, and most of the pain conditions I deal with are at least propagated by inflammation, if not caused at the beginning by inflammation in some way. And I look at it like metabolic syndrome is like throwing gas on the fire. Somebody has arthritis in their back and they have terrible diabetes or metabolic syndrome. If I can just stop throwing gas on the fire, they're going to do better, regardless of what else I do for them. And there's a lot of mechanisms, I think, behind that, whether it's in metabolic syndrome, whether it's, just eliminating the processed foods. I think that there might be something to ketosis in and of itself that's anti-inflammatory. From a nerve function standpoint, going back even to the seizure literature, we have some evidence to say that ketosis or sort of low carbohydrate nutrition patterns are beneficial from a hyperexcitability in the nervous system standpoint. So there was a really great lecture out there. I can't remember when it was from, what conference it was, but it went through, ketosis being beneficial from a inhibitory neurotransmitter standpoint. So it augments inhibitory neurotransmitter release and quiets down excitatory neurotransmitter release in a way that reduces hyperexcitability. In chronic pain, you have both central and peripheral sensitization, where both the central and peripheral nervous systems are hyperexcitable because of sort of repeated pain stimulus. And it's not exactly analogous to a seizure, but it's sort of somewhat similar. And so that might be another way that sort of ketosis and or carnivore ketogenic style diets are a benefit. Then the fourth one that I think about all the time is mood. We're finding out more and more nowadays about how ketogenic carnivore style diets have an immense potential to improve things like depression, anxiety, schizophrenia, bipolar disorder, even neurodegenerative diseases, Alzheimer's, dementia, Parkinson's. And those diseases are so heavily tied in with chronic pain, such that if you improve one of them, the other often improves. So if I've got somebody who's in chronic pain and depressed, if I improve his pain, his depression might improve, but it goes in the other direction too. Where if I improve his depression, sometimes his pain will get better. Well, luckily, ketogenic and carnivore style diets do both, it seems like. And so that can be very, very beneficial for a lot of people. I think there's probably more mechanisms out there that we don't know enough about. I think about the gut microbiome a lot, and I hesitate to make too many claims about that because I think we're in our infancy as far as what we understand there. But my suspicion is at least getting rid of the junk improves the gut microbiome, and that probably leads to sort of better inflammatory milieu and improvements in chronic pain as well.
Yeah, I mean, obviously you're on social media. I'm on social media. There's a lot of people on social media. Somebody sent me a thing today from a cardiologist, said the last thing I would do, one of the top 5 things I would never do for my patients is put them on a ketogenic diet because, LDL and heart disease and so on and so forth. And you're seeing clearly a improvement in quality of life for these people. And so what are your thoughts on that whole relationship? Are you the net effect of improving somebody's quality of life? Maybe you're increasing the risk of heart disease. I don't know that we know that. What are your thoughts around that whole topic?
I guess the way I look at it is barring some sort of genetic abnormality, barring familial hypercholesterolemia or some other genetic variant, like you say, on balance, we are improving all of the risk factors that we know for sure are problematic from a heart disease standpoint. Metabolic syndrome in and of itself, aside from smoking, is, arguably the biggest risk factors that we can modify for heart disease risk. And so we have this thing in carnivore and ketogenic style diets that improves every aspect of metabolic syndrome. And, LDL isn't on that definition list of metabolic syndrome. And so I get this question a lot from my patients where, well, what about my cholesterol? And I go through, well, it's probably more about what's happening with triglycerides and HDL and LDL particle size, et cetera, than the numbers themselves. And, I think when you see everything else getting better, except for the LDL, number itself, when we don't really even have, solid evidence that that's a problem, I don't worry about it.
Yeah, it's curious that metabolic syndrome, which, triglycerides, HDL, glycemic control, blood pressure, absence of presence of cardiovascular disease does not include LDL in that definition, which is interesting. Why would metabolic disease get better and LDL get worse? It seems like a weird relationship where, your heart disease risk went down, but it went up at the same time. And it's curious to say that, to say the least. Do you have any, I couldn't tell you how many corticosteroid injections I did over the years as an orthopedic surgeon. I probably did 30, 40, 50 a week in my clinic, and then occasionally in the operating room, but usually just in the clinic, probably in a number of thousands. And, you see some of the literature coming out, obviously it messes with your glycemic control, even though it's a local injection, you can still see that. Some people's blood glucose spike for days, even weeks at a time. There's been studies out there, particularly with repeated corticosteroid injections in the spine, that there's an increased risk for osteoporosis in that area. And I know it's part of your practice, and you're probably doing selective nerve root blocks and so on and so forth. Do you have any concerns with that when you're sitting there going, God, I could probably fix this with a damn diet, and here I am? Or do you have any concern about that? Do you think it's a real credible issue? Is there any downside to what you do?
I think there is. The old days of pain management 30, 40 years ago, people did these steroid injections a lot more frequently than we do them now. They were doing them every 2 or 3 weeks and maybe for years and decades. And I think that really got people in trouble from the standpoint of blood sugar issues, bone density issues, like you mentioned, hormone deficiencies, heart failure, kidney issues, all these things. And, luckily nowadays, for people that don't have terrible uncontrolled diabetes or metabolic syndrome, a one-time steroid injection every so often does not tend to be too much of an issue. We space them out at least every 8 weeks or 12 weeks to sort of minimize that risk. But you're right. Though I have a gentleman who's a type 1 diabetic, and anytime he gets a steroid injection, his blood sugars rise to DKA, ranges. And so we have to be very judicious. And that's part of the reason we exist as a pain management field, is to try to find other avenues. But you're right. I talk about nutrition in those cases, especially all the time, because if I can improve your pain in a way that doesn't involve me having to give you a steroid injection, you're going to do better. Or at the very least, if I can get your blood sugar and your insulin, resistance under control such that you're able to have these injections every so often and not have tons of side effect or downside to it, that at least is some benefit.
Most people realize we went through this, and still probably are, in this huge opioid crisis. Lots of people dying from opioid. Think fentanyl overdoses are huge. That's part and parcel of what you do. I know you're prescribing high dose, high spin. I've seen some people on just massive doses of narcotics. I was scared even, when they get admitted to the hospital. I'm like, you want me to write for 2,000 milligrams of morphine? It's like, it's just crazy stuff, right? Mm-hmm. Is that getting worse? I mean, are you seeing, is the prevalence of chronic pain increasing in incidence? I mean, and granted, your career has not been that long, but does the data support that we've seen more and more people in pain?
I think so, on average. I mean, the most recent statistics are that 1 in every 4 adults deals with some element of chronic pain. And so I think it is probably increasing, especially as some of the baby boomers age a little bit. And the opioid epidemic I don't think it's getting worse at this point. And certainly the practice that I'm in, we are very judicious about opiates. There's a whole spectrum of chronic pain physicians out there. The practice I used to work at, we didn't do zero. We just did purely interventional work. And that's fine. But there's a lot of people out there that we're not going to be able to help because of that sort of stance on things. The way we handle it at our practice is, we make sure, number one, if somebody comes to me on opiates, or I should say, if they come to me not on opiates, I don't start them on that unless I have a really, really good reason to do so. And the best reasons are cancer pain. Somebody has surgery, go and has a knee replacement or some other procedure done. They might need a short course, or they, fall and break their ankle or have some other trauma. Aside from that, everything else is a gray area. And, so we try to minimize the dose, try to wean people off as much as we can, utilize some of these other strategies, whether it's nutrition, whether it's interventional procedures, other non-opioid medications as much as we're able to maximize benefit while minimizing risk. And, I think that tends to work out reasonably well, but it's still a big deal. It's the opioid presence is everywhere.
It was interesting. I talked to a friend of mine. I think he was an orthopedic surgeon, and he was overseas in Europe, and I think he broke his clavicle skiing or something like that. And they would not give him any sort of narcotic pain medicine outside of the inpatient facility. So we just don't prescribe this stuff outpatient, which I thought was kind of interesting, because here in the U.S., it has been given out like candy in the past. I mean, you mentioned baby boomers, so that implies older people tend to have more chronic pain, which kind of makes sense. Are there any other sort of predictors for somebody who's going to have chronic pain? Can you say obesity or metabolic disease? Or what do you see in your practice? I'm sure there's literature that shows association between this condition and the development of chronic pain. And if so, what are they?
Certainly, metabolic syndrome and the components of it. So obesity and type 2 diabetes are definitely risk factors. People, for certain conditions, it changes, right? So for example, fibromyalgia is one that we see on a regular basis. Younger women tend to be a little more likely to develop that as a chronic pain condition. Higher doses of opioids before a surgery, for example, is a risk factor for predicting long-term opiate use. And just age at the end of the day. That's part of the reason I mentioned baby boomers is that it's, age is an independent risk factor for it as well. And so, I think about the statistics now about, 88 to 93% of our adult population is metabolically unwell in some form or another. At least that's what I've seen most recently. And I think that people who have chronic pain are a lot more likely to be suffering from chronic metabolic disease and vice versa. And so I think that those two things go hand in hand.
Yeah, one of the things about that super high prevalence of metabolic unwellness they're using LDL cholesterol as one of their benchmarks. And so you could say, well, I don't know what percentage of people have an LDL above 140 or 100, right, which is a number that you can pronounce. Probably you've already sort of categorized 60% of the population that way or something like that. Let me ask you, this is just out of pure personal curiosity, because I've seen some discrepancies in the literature on this. How often do you see people post joint replacement that are still having refractory pain, total knee probably one of the more common ones, but how often does that come to your attention?
You see it a lot. And, I always take this with a grain of salt, because we don't see all the people that go home and do great. They're not coming to me if they've had a knee replacement and they're doing fantastic. The literature, I think, is anywhere, but it's pretty broad in terms of some of the studies that are out there. It's for example, back surgery, the failure rate, so to speak, of back surgery is anywhere between 10 and 40%. So it's very, very wide range. I would say I'd have to look at the evidence again as far as some of the joint literature, but, I would say it's somewhere in between there and probably on the lower end, but it's still common enough, especially knees, for whatever reason. We see a good amount of people after total knee arthroplasty that still have trouble with knee pain. And
how many of them, just out of curiosity, just to dig into this point, how many of them are suffering from obesity, metabolic syndrome, things like that when they come in with it?
Vast majority.
Yeah.
I would say the vast majority, and also smokers. I should have mentioned that before. Smoking is also an independent risk factor for chronic pain.
Yeah, it's one of the things, if you read the orthopedic literature around joint replacement, everything looks like it's perfect and rosy and everybody does great. Then if you start looking at the anesthesia pain research, you're saying, wait a minute. And I just wonder how biased and skewed the literature is depending on who's interpreting that. And what I suspect is, obviously when you're doing a joint replacement, you're replacing the surface of the joint, but you're not taking care of the synovium, you're not taking care of the soft tissue, which is still inflamed and irritated. And, so if you don't, again, address the chronic metabolically, I think, driven inflammation, you're not taking care of the problem to the full extent. And probably that's what you're seeing. I imagine, as you mentioned, they also have that common factor. So I'm sure you're not in solo practice. You're probably I guess you're part of the pain group would be my guess. Your partners, they think you're a nutty guy? Are they into this keto stuff, or what's your thoughts?
They, yes, they think I'm odd. Most of them, if I start talking about this, they just kind of glaze over. Most of them don't have a whole lot of interest in thinking about this. In my old practice, I kind of wound up accidentally starting a little mini clinic within a clinic for this. And it's probably something I'm going to be doing here in my new practice. I just moved to this practice about 8 months ago. And so I'm still sort of integrating myself into the area. But none of the chronic pain physicians that I, interact with in my group, or even outside, when I go to conferences and things like that, nobody's talking about this for the most part. And I think that's a shame. I think that we're missing part of the picture.
Yeah, and I think a big part. And it's funny because, as a surgeon, the more procedures you do, the more you make. And it's how can I more efficiently, effectively, and what's the latest gizmo that can make me do this procedure quicker and faster, and that type of stuff. So I see that the disincentive to do what you're doing, which I applaud you for, because you're in a field where it doesn't pay you to talk about ketogenic diets. It pays you to be in the procedure room and doing injections and blocks and so forth, and stimulators and so on and so forth. So when you actually have the time and the opportunity, what resources are you using to help edge this? Because, like when I was doing it, I'd hand out a flyer. Here's a flyer, here's some videos I want you to watch, here's some books I want you to read. It's just not really, you just don't have the nice facility to say, hey, here's a whole video series, here's some coaching you can get. What are you using?
So I kind of do something similar to what you were talking about with flyers. I give, a packet of information to them, and included in that are a lot of the resources, either in social media, Facebook, books, your book and probably 25 other books that I've read that I think are really useful for patients to think about reading. And I tell them they don't need to read them all, but here are just some resources for you if you wanted to read more, and I encourage them to do so. And a lot of it is just starting that conversation and pointing them in the right direction. not everybody's going to, take it and run with it. And, but I don't think that means we shouldn't try. And it's a good question because, one thing that I'm, working on right now, my wife and I are working on developing an online course that would walk patients through, how I think about ketogenic style diets in relationship to chronic pain, and sort of giving them the basics on how to approach that, how to set that up, what things to watch out for, and generally speaking, what things to be eating and when. And so we're building that right now. So it's always a work in progress. I think one of the biggest things that I need to work on is the community aspect, which I really like what you guys are doing at Revero. Another community that I really enjoy is Joan Ifland's work, which is a lot of
addiction.
Yeah, food addiction. And what I've seen when people struggle to be consistent with this, and myself included, I have a little bit of this where I have, I'm just as addicted as everybody else is to processed food if given the opportunity. That's why people fail more than something about the diet itself. It's not that what they're doing is unsustainable. It's that they live in an environment that's not conducive to being consistent. And one of the people in Joan's community put it this way, for people with processed food addiction, we are alcoholics living in a liquor store. And so, giving them the information is one thing as far as the nuts and bolts of how to eat and what to eat and all that, but giving them the support to actually implement it in a way that is sustainable and supports some of these sort of more psychologic, behavioral aspects is a whole nother aspect.
Yeah, we're never going to get out of the liquor store. I don't see any time in the future where all the processed garbage is going to go away magically. So you have to figure that out. There's a couple of questions in here. I just want to I'll just sort of address these and see if you have any comments. Somebody's asking if you're familiar with Glossopharyngeal neuralgia. I'm not sure how do you treat it? Is there a typical treatment for that?
Yeah, that's a really hard one because, from an interventional perspective, you're not going to want to be either doing a block or a radio frequency ablation of that cranial nerve or that set of cranial nerves. And so that's a really hard one to treat. I would imagine doing what you can from a nutritional perspective on top of neuropathic, nerve pain medications. There probably are a handful. If I had to guess, there's probably some neurosurgeons out there that would consider doing something more involved for that. But, it's a tricky area and you don't want to screw it up, basically. You don't want to give somebody cranial nerve 9 and 10 paralysis or paralysis.
Yeah, that's a challenging issue for sure. There's a question about ketogenic diets and ketosis. Are you, like, when you counsel somebody, hey, let's try a ketogenic diet, are they measuring ketones, or what kind of metrics do you ask them to do? Or you just give them some general dietary guidelines and let it happen naturally, I guess?
I think it kind of depends on the person. Most people don't want to be that sort of meticulous about their nutrition. It can be overwhelming for a lot of people. But for the people that are interested in doing that, I think it's not a bad idea, but I don't think it's required. And the reason I say that is it's not going to change what I recommend most of the time. I don't, this isn't quite the same as treating seizures in that when you're doing this for epilepsy, part of the idea is you want to be in ketosis as much as possible. I look at ketogenic diets for pain as you want to be in ketosis more often than you are already with the standard American diet, but it's not like you have to be in it all the time, 100% of the time. And I think that measuring ketones sometimes, depending on the way you're measuring it, can lead you astray a little bit, especially urine ketone measurements. I think, except for sort of the initial phase there, where you're keto adapting, after that, your body starts utilizing them a lot more. And all of a sudden your urine ketones might go down, even though you're eating exactly the way, you want to be eating. And so I just look at it like if it's not going to change my recommendation, which is to eat real, whole, single ingredient food, mostly meat, mostly vegetables, depending on sort of their individual preferences, with other things being very, very small garnishes, little bits of dairy, little bits of nuts and fruit, maybe. That stance isn't going to change too much, depending on what your ketones are doing.
All the questions in here. So your opinion on things like, I guess I'll go through all these: prolotherapy, PRP or platelet-rich plasma, stem cell injection. Do you feel that there's a lot of literature that supports your use? Are they efficacious? Have you had experience with any or all of those?
I have more experience with stem cell therapy than I do prolotherapy. The thing with stem cell therapy is the data is very mixed and highly variable. And what I mean by that is there's a million different ways or several different ways to formulate the stem cells. Where are they coming from? Which particular cells are they? How do you deliver them? And even in the best of cases, when you have those things consistent in the literature, the benefit is mixed, 50-50. And so I don't use it right now because it's, number one, it's out of pocket. And so it's very expensive for people. And if the data is that mix, I can't make a real strong recommendation to use it. I think the same thing is true for prolotherapy, with the exception that it's not as expensive and it's less invasive, less risky, because you're not harvesting the patient's stem cells to do it. You're essentially using sort of saline to break up, for lack of a better term, scar tissue. And in either case, it certainly helps some people, but I don't think the data is robust enough for me to make a strong recommendation.
Yeah, I know if I look at the American Academy of Orthopedic Surgeons recommendation, they're pretty much not particularly up on stem cell. They say kind of the data doesn't really support its use. And same thing for PRP and prolotherapy, at least from the field I was in. So I don't know if the pain literature is any different. As far as, I just come out of it for the last few years, but is there any kind of new things that have come up in the world of pain management in the last 5-10 years that are kind of game changer type things, or what are you guys doing these days?
Most of the pain world is very focused on devices and, procedural options. And so the further we get, down this road, the more pain physicians are doing things that they never would have done 10 or 20 years ago. For example, I'm trained in dorsal root ganglion stimulation, which, we place an electrode over the dorsal root ganglia. So for example, somebody has broke their ankle and still has developed complex regional pain syndrome or neuropathic pain in their foot and ankle. Traditionally, you would use spinal cord stimulation to drown out some of that pain, but dorsal root ganglion stimulation is a little more specific to the ankle and foot and has better evidence for it. So that's sort of one example of where things are going. We've started to do minimally invasive SI joint or sacroiliac joint fusions that doesn't involve hardware, where we put basically a shim that includes some donor bone, a little bit of the patient's own bone, and a little bit of matrix proteins in a way that sort of fuses the joint via the patient's inflammatory response without us having to do something like rods and screws like orthopedic surgeons have done. So things like that are where the field is moving towards. The medications are the same basically as they have been for many, many years, and they all have their pros and cons. So that's not really advancing, I wouldn't say.
Yeah, so more just slicker and slicker procedures. And for those who know, the point of fusing a joint is it hurts when you move it. So you stop it from moving, then it's theoretically going to stop hurting. And I'm just wondering what the success rate, because a lot of, and again, it's going to be, you don't trying to do that in a smoker, an obese diabetic, success rate is going to be probably pretty low, I would imagine. Or I don't know, maybe it's not, maybe it's gotten where it's better, but the same old type of things. Have you, so you'd mentioned, you've got a lot of these morbidly obese patients, and as you know, they're more challenging to work on. It's technically more challenging to access certain areas in the body when you have to go through 6 or 8 inches of body fat. I mean, it's just the way it is. And it's a real challenge. How, as far as, do you do anything with like Suboxone? Is that something you're in your purview? Because that's one of those things where, people don't know that's a medication they use to get people off pain meds. Is that, do you do much with that?
I do. The group that I work with currently has the pain group, but also we have an addiction medicine sort of arm. And so Suboxone, which is buprenorphine with naloxone, is a great medication for the addiction part of things, but also more and more we're using it for pain itself. And, if it were up to me, if I had to start somebody on an opioid medication for long-term use, I would prefer to start with buprenorphine because it has such a nice ceiling for safety. It's very, very, very difficult to overdose on it, either on purpose or on accident, because of that mixed or partial agonist antagonist effect of the opioid receptors that it has. The issue is insurance. Not a lot of these insurances will cover it. And it's amazing to me because they want me to start these patients on long-acting morphine and fentanyl patches before they'll cover a buprenorphine product for pain. So we struggle with that all the time. But yes, we do use it.
Yeah, it's interesting that they prefer you to be on fentanyl pads than something like that. That is quite interesting. As far as your own personal diet, you mentioned carnivore, that's still considered very controversial, and particularly because you're making cows fart and boil the oceans and stuff like that. What does your personal diet look like?
What works the best for me is something that is mostly carnivore. I'd say 95%. The vast majority of my nutrition, comes from steak, eggs, meat, fish. And, I have like before my workouts, for example, I'll have a little bit of like whey protein because it's 4 a.m. and it's convenient for me to do that as opposed to me eating a big steak and being full for 3 hours. And I'd probably vomit if I did that, to be honest with you. And then I'll have a little bit of vegetable matter as like a garnish. Like, for example, we'll do like a burrito bowl night where we'll make some ground beef and I'll have some onions and peppers with some salsa, right? Or, when we make burgers, I'll have a little bit of tomato and onion on it just as a topping, without the bun, of course. So I'm not like pure 100% sort of carnivore, but that works the best for me. Personally, my digestion is great. I feel great. My energy is great. I sleep well the vast majority of nights, and my weight has regulated. I'm putting muscle on, without really trying like I used to, and it fuels my workouts really well. And so that's what works the best, for me right now.
And do you have at work, you bring in something to work and then people saying, what the hell are you eating this steak at work for? Do you get much of that?
I get a lot of raised eyebrows. Yeah. Because I walk in and, most weeks I make a bunch of ribeyes on Monday, and then I eat, part of that for Monday night, but then I have steak the rest of the week, and I'll put some eggs in there and maybe, some sausage or something like that. And I'll bring that to work and people look at me like, what the heck am I doing? But that doesn't bother me.
And how old were you? How old are you again?
34.
34. So you're still relatively on the younger side. I'm sure they're asking you about heart disease. Do you check your cholesterol and all that stuff? Is that something you look at?
I did. So it was very interesting when I was in medical school. I don't know why I got some labs done, but I did at that point. And I don't remember what my total cholesterol was, but my LDL was, 150. I think my triglycerides were as much. It was about 150, and my HDL was like 38. It was low. And genetically, that's the way my dad is sort of too. That's his baseline pattern. And the last time I got my labs done, my triglycerides were basically undetectable, and my HDL was 71. And my LDL cholesterol, I think, was 170 or something. So it was dramatically different and in better.
The people, the sort of the cholesterol theory folks would say, you would say your ApoB to ApoA1 ratio actually improved with your HDL going up that much, and your LDL going up only a relatively small amount. So probably decreased your risk of heart disease based on those numbers, which are, as you know, a snapshot, a 1 second snapshot in time, and you don't know what's going on every other day of the week or whatever. But interesting.
What was cool about that was that in the same time frame, I did a DEXA scan too. And so at the start of that process, I did my body fat was around 22%. When I finished that process, I ended up at around 12 or 13%. So, all of the metrics that you would think about, worrying about went in the right direction, right? My triglycerides went down, my HDL went up, my body fat percentage went down. I didn't have high blood pressure at that point, nor diabetes, but I didn't do a pre-fasting insulin level, but my post-fasting insulin level was 2.
Yeah. How do you like Jacksonville? I mean, I don't know where you moved from, but did you move from Jacksonville to Jacksonville, or did you move from out of state, or where did you come from?
I came from Madison, Wisconsin, and we love the weather here. We're able to be in the pool 5 days a week or more, and I don't have to get up at 4 a.m. to plow the snow on my driveway. So it's a lot more enjoyable. We miss a little bit of the seasons. And I mean, I lived in Madison for almost 15 years between all my training and the first couple of years in practice. So I miss that a little bit, but the weather's hard to argue with.
Yeah. And there is, what was I going to say, as far as, the weather is certainly nice in Florida. There's a more members in Jacksonville, so he's excited to see another doctor, and hopefully he doesn't need a paying doctor, but it's good to see people out there. Is your family, I mean, I think you said you had a wife, I can't remember, on board with the diet, or is she thinking you're nutty too? Or?
No, so my wife has a couple of things. She has Crohn's disease. She has been diagnosed with small intestinal bacterial overgrowth, and has struggled with autoimmune conditions most of her life, Hashimoto's thyroiditis. And, she was dealing with this for a long time. And a year and a half ago or so, I said, I think you would do best with the carnivore strategy. And she wasn't ready yet. But with all the things that she's tried, and she's tried a zillion things, she's tried the elemental diet, she's tried all kinds of medications. And where she is now, she does the best eating very similarly to the way I do, whereas the vast majority of her diet is carnivore. When she deviates from that, she notices she gets flares. Her GI issues flare up. And so, she is definitely on board with this. My 6-year-old and my 2-year-old, that is a work in progress. Unfortunately, because as you say, we are not getting out of the liquor store, and sort of convincing a 2-year-old child that eating, meat and or vegetables is a good idea can be an uphill battle. So we're doing what we can.
Well, I don't force my kids to eat vegetables, so it makes it a hell of a lot easier. I can tell you that. I mean, but they usually do pretty good with meat, so that's something. But as far as I guess you said you're planning on putting together a course, and I know you're on social media. When do you do the social media? Do you do it after work or on days off? Do you have to take call? Is there any call with your practice?
Sort of. No official call, and that's one of the nice things about pain management as a specialty. Right. I'm not in the hospital on the weekends or at nighttime. If there's somebody after hours that has a question, they can call the answering service and they can get a hold of us if need be. But it's rare that something comes in that's actually something worthy of having to go in or something like that. But I social media is something I do kind of when I get spare time. My wife is actually a lot better at doing some of it than I am, as far as putting together like all the graphics and everything about it. But so she helps me a little bit. But it's something that I've had to force myself a little bit to do, because it's not something that comes natural to me necessarily. We don't get any training on how to be, have a social media presence, or entrepreneurs in medical school and residency and fellowship. But I'm using it as a way to sort of bring the message to more people than I can see in clinic alone. And that's a big part of the reason that I'm doing the course too, is that I can only see, however many patients in clinic on a daily basis, whereas I might be able to sort of reach more people, doing something that's more broadly available with something like a course.
Yeah, I don't think you struggle to find patients, probably. I mean, you probably have to do zero advertising. You get a full clinic schedule probably most of the time. So it's not, because there's so many non-sick people, and that's the interesting thing. In fact, your wife, it's interesting, Crohn's, and I've seen so many people with Crohn's and ulcerative colitis and some of the other autoimmune diseases that do very well with carnivore style diet. And it's almost as if that should be the frontline default position of gastroenterologists or other people dealing with these types of conditions. And I don't know, did her gastroenterologist, I assume she had one at some point, talk about diet, or was he or she in the camp that diet has nothing to do with your gut function? Which that statement alone just drives me nuts. But what were the thoughts with that?
Zero discussion about that. My wife has gotten, she's gotten the most help in that regard through sort of a concierge company that she has found on the side that does, a lot of specific small intestinal bacterial overgrowth work. And they sort of talked a lot about diet, not specifically carnivore. They didn't label it that way, but it, if you read between the lines, that's pretty much what they're, trying to get you to do. And from a pain standpoint, when I see somebody with chronic autoimmune condition, rheumatoid arthritis, any autoimmune polyarthropathy, ankylosing spondylitis, those are the people that I point to carnivore quickly, sooner than later. And I tell them those are the people that have had the most dramatic improvements, I think. People who do this for a month or 2 months or a couple of months and their symptoms are, maybe not gone, but like dramatically improved. I had a patient with Lyme disease with the classic migratory polyarthritis, and 6 weeks gone, and I mean, my general philosophy is I don't talk in terms of cures. I try to under promise and over deliver. But when I see that kind of results, it's hard to argue with it. Rheumatoid arthritis the same way. Some people just respond incredibly well to that, such that they can come off of the steroids or they can come off of the methotrexate or what have you.
Yeah, I mean, particularly if you get them early before all the joint deformities occur, it's one of those things. Like, gosh, hopefully enough of us can get the message out there that the general community can adopt some of this stuff, and at least, I don't know how many people you'd end up avoiding all these horrible, complications and unnecessary medications and procedures and whatnot. But it's a tough hill, and now we're fighting the climate activists trying to ban meats. Are you concerned about that at all? Is that sort of, I mean, probably in Jacksonville it's not as big of an issue as it may be in some other places, or maybe it is, I don't know. Any thoughts on having people dictate what you're allowed to eat, or are you concerned about that?
It is something that I don't think they have any business telling us, what we should or shouldn't be eating. And there's no credible evidence in my mind that links, the animal food industry with any significant portion of climate change. I think there's a lot better explanations out there for why we have climate change the way we do. I think it's such a political and or ideologic topic, religious topic for so many people, and that doesn't have any place in science, to be honest with you. And I think they're using the science as a vehicle to push what they want on other people, And I think it's unfortunate because most of the people out there in this space, the ketogenic carnivore space, are not that way. If I have somebody that comes to me who is vegan, right, and that's what they want to do, I'm not going to try to convince them otherwise unless they have questions for me. My job is to just give them my opinion about the risks and benefits. And if they want to keep doing that, great. And if they're doing well, I'm not going to argue with that. I'm not going to push sort of what I think is the best for them, onto them and try to convince them. Unfortunately, the opposite is not always reciprocated by those communities. And I think that's a shame.
Yeah, I think it'd be fair to say, and correct me if I'm wrong, you say that nutrition probably plays a role in the etiology of pain, chronic pain, perhaps, and it may have a role in the improvement of that. Are those fair statements?
Yeah, absolutely. I think it's a big part of it. I think that especially metabolic syndrome either causes and or magnifies people's pain consistently, whether it's coming from arthritis or nerve-related dysfunction. I think it's a big deal.
Chris, we're running out of time here. I really appreciate you coming on, and certainly appreciate what you're doing and being courageous enough to stand up and do this in a place where not a lot of people are willing to do this. Perhaps at some loss of income for you, or who knows. Anyway, where do people go to find out more about you? Tell us about if you've got websites or your social media handles and that type of stuff.
Yeah, so people can find me on social media, on Facebook and at Instagram at Keto Pain Doc. And again, I'll be in the next sort of couple of months. We're developing this online course for people with chronic pain. Going through how I approach ketogenic and/or carnivore style nutrition to help with them help their chronic pain. And so that'll be coming out here in the next little while. We're just putting the finishing touches on it. I appreciate the opportunity today. It's an honor to be on the podcast with you and all the people that you've helped in the past.
Yeah, one other thing I wanted to I know because we talk about diet, but I'm sure when you put out your course for chronic pain, you're going to talk about some other things outside of diet, probably stress and mindset type stuff. I assume. Is that correct? Yeah.
Yep.
Yeah. Well, Chris, thank you very much. Have a great rest of your day in Florida and keep up the good fight. And we'll talk to you down the road. Okay.
Thanks, Shawn. Take care.
All right. Bye-bye, everybody. See you tomorrow.